serving the people of Louisiana since 1934.
Welcome back. In this next segment, a very brave woman shared with us her story on recovering from breast cancer and also tells us about her experience in breast reconstruction surgery and her outcome. Take a look.
I was diagnosed on a routine mammogram. I had my previous mammogram had showed calcifications, which turned out to be no problem. Calcifications are normal in women my age, and so on this last mammogram, went back in, and the calcifications had changed, because there are good ones, good calcs and bad calcs, as they told me. The bad ones turn into cancer. So the radiologist recommended that I go for a needle biopsy, and I did. The needle biopsy was just a few days later. They moved very quickly. And the results of the needle biopsy were that I had a cancer. It's commonly called DCIS, ductal carcinoma in situ, which means it's in the milk duct. And in my case, it was very, it was very confined, and it was slow growing. So, you know, they didn't have to move too quickly on my surgery. So I had over Christmas to wait before I went to the doctor and find out the rest.
Miss Albert was referred to me by a breast surgeon for evaluation for breast reconstruction. She was found on mammogram to have some suspicious findings that led to a biopsy. After the biopsy, she was diagnosed with breast cancer, and usually what happens is the breast surgeons are the doctors that get the patient, and they'll refer them for breast reconstruction, and that's how I met her.
I did not have a history of breast cancer in my family. This was completely random. And so it was a surprise in that I had no history. I'm not one of those people to say it'll never happen to me, but no, in that respect, it was a surprise, yes.
In my evaluation with her, we discussed several options for breast reconstruction.
After I got the diagnosis, I saw the surgical oncologist who discussed the different options with me. The least invasive would be the lumpectomy, which I would have to be treated with radiation, and then followed up by, I think, 5 years of tamoxifen, and then whatever reconstruction if that was necessary. Or I could have gone with a full mastectomy, which would have meant no radiation, no chemo, but possibly the tamoxifen following. I decided to go. I asked to go with a bilateral mastectomy to wipe out any possibilities of further breast cancer. And so, because I made that choice, I did not have to have radiation, chemo, tamoxifen, or anything like that.
In order to prepare the patient for the surgery, I usually have them do an imaging study of the donor site area to evaluate the patient's blood vessels, because the surgery is based on transferring tissue with blood vessels to have a microsurgical anastomosis so that the breast is always supplied with blood flow, and it also has drainage of blood. The day before surgery, I usually see them in the office. I mark them, and both the breast and the donor site. And during the morning of surgery, everything is already preset. Patients come in, they get rolled into the operating room, and then we get started. In her case, she had good amount of tissue in the back of her thighs, and we decided to perform a PAP flap on her, which stands for the profunda artery perforator flap. Basically, it's the tissue from the back of the thigh underneath the buttock crease, and it usually brings enough tissue to make average size breast for the average woman. Usually the patients are in the hospital 3 or 4 days after the operation, during which time we monitor the breast and the flaps to make sure that our anastomotic hookup is patent. And we evaluate them for pain and make them comfortable. They have drains. Some of those drains come out before they go home. I usually see them 3 or 4 days after they're discharged from the hospital, at which point I take out the remaining drains, and after that it's usually a smooth recovery where we don't really have to even take sutures out because the sutures that we use are absorbable.
Looking when I lifted the covers and looked after the surgery and saw that I looked fairly close to normal, not totally, that was a huge relief. It did a lot for my peace of mind. And I didn't know what to expect. I had no idea what to expect, and that was a very nice surprise.
The shape of the breast is usually a cone. What's perceived out there in the general sense is that you would bring some tissue up to the chest wall and just leave it there, and that would be a breast, which is usually not the correct thought pattern. The breast has to be conical in shape, it has to have projection, and it needs to be round and smooth. Now with the nipple-sparing mastectomies, we're able to leave the nipple on, so whatever tissue we're placing underneath the skin of the breast and the nipple of the breast stays underneath. Therefore, the flap being a crescent-shaped flap, and if both ends of the flap are brought together, it provides that conical shape for the breast, which is very natural. It has the actual natural sagginess that the breast has and the natural feel of the breast. The benefit of using patient's own tissue for breast reconstruction is that it provides a natural look and natural feel to the breast, and it ages with the patient, so that you don't have to have revision surgeries several times through the lifespan of the patient. The best site to take tissue from usually is the abdomen, as patients are usually a little older when they present with breast cancer, and they've usually been pregnant, so there's some tissue underneath the belly button that is available to be used for breast reconstruction. But however, not everybody has that. The typical flaps that have been used are either the buttock or the inner thigh, but with this new flap, the posterior thigh flap, the pap flap, we were able to conceal the scar underneath the buttock crease, which is something that the patients like. They are not able to see the donor site, and the tissue is readily available in most women there. As opposed to breast reconstruction using implants, usually sometime down the road there's some revision work that needs to be done with implant-based breast reconstruction.
Oh, he's wonderful. He's very accessible, very easy to get along with, to joke around with. We've talked about other things. As a matter of fact, I just watched a movie that he recommended to me, just in our casual conversations. But he's very easy to talk to, and at the same time extremely knowledgeable.
So with Miss Albert, I think we hit a home run. She did very well after this operation, and this was the perfect operation for her. She is happy. She's got symmetric breasts that are natural looking, and I don't think we would have been able to do it any other way.
My recommendation would be, do not miss your mammograms at all. I don't care how afraid you might be of it. Take someone with you, do whatever it takes to go and to do that. And also know all of your options. Get on the internet and read, be informed. Honestly, the bilateral mastectomy was never mentioned, and I was the one who asked about that. I was told I could have a lumpectomy or a single mastectomy, but when I brought up the topic of bilateral, oh, well, yeah, sure. And for anyone who's concerned about insurance, I was told back in the 90s that a law was passed that insurance companies, in the case of breast cancer, must make you symmetrical after breast cancer surgery. They have to do that. So if anybody's worrying about that, because I know that is a concern for some people. So it was for me. So yeah, those would be my recommendations. Don't skip your mammograms and be informed. Make that your job.
faces of our people. There's a tale of where we're from, and it tells us all